This is a demonstration of how to use the new appendectomy and cholecystectomy Synoptic operative reports. The first step is to go ahead and log into Sunrise Clinical Manager. To complete a Synoptic cholecystectomy operative report, you'll choose Enter Document. Again, if you type OP, it will bring up the two relevant operative reports. You can choose cholecystectomy. Again, you can choose today's date by clicking the little watch sign. You can indicate whether the surgery was elective or emergent, what the diagnosis was, what the exact procedure completed was. If you choose an open procedure or a laparoscopic converted to open procedure, you can see that in this area here, there are options for why you needed to do a different procedure. If there's another procedure that you ended up completing, you can indicate that. You can indicate whether any additional procedures were completed. And again, there is a space later for lysis of adhesions. Once again, you must by hand type in the physicians, the surgeon, and the anesthesiologist. If you wish to type in any clinical history, you may in this area here, although this is contained in the written chart or the outpatient consultation. You can indicate what preoperative imaging the patient underwent. You can indicate what antibiotics the patient was given, what thromboprophylaxis was used, and whether the checklist had been completed, and whether the abdomen was clipped of its hair, and whether there was a urinary catheter used. For the procedure itself, you'll indicate the access, so typically a Hassan, but not always, located in a periumbilical or epigastric location, how you close that Hassan with an absorbable suture, and the method of closure, and what other trocars you used, such as two 5mm trocars and a 12mm trocar, for example. And it asks you whether or not you closed the fascia of the 12mm trocar. If not, you could say why not. Whether you completed any adhesiolysis, the appearance of the gallbladder, the anatomy you identified during the course of your dissection, or alternately, if the dissection was very difficult and maybe you just completed a laparoscopic cholecystostomy tube placement, you may say the anatomy was obscured. You can indicate if there is an intraoperative cholangiogram, whether you obtained your critical view of safety. If no, you can indicate why not. How you controlled the cystic artery and how many clips you used. How you controlled the cystic duct and how many clips you used. Whether the gallbladder was perforated. If so, was there bile that was spilled, pus that was spilled, or stones that were spilled? If the gallbladder was removed with a bag and where you removed it. If you need to complete any hemostasis to the gallbladder fossa or liver bed, and if so, how you did that. If there are any drains, and if so, where you left the drain. And the reason. Ignore this line regarding the epigastric fossa. Whether local anesthetic was injected, how the skin was closed, whether there was any estimated blood loss more than a minimal amount, if all the sponge needle and instrument counts were correct at the end of the case, the disposition plan for the patient, and if there are any complications, and if the patient was being prescribed any postoperative antibiotics. Again, you have the option to copy other providers on the operative report and send it to the patient's family physician. And again, if everything is complete, then you can click yes and eventually save in the bottom right. But before you do that, again, for the trainees, for residents, it's critical that they choose this document being authored by someone else and that they choose the appropriate surgeon so that the surgeon will receive this report and be able to sign off on it.